Okay, volume is good. I can't hear anybody, but that's probably me because of I probably muted things. So if somebody can try talking.
Can you hear?
Now I can. Perfect. I had muted it because I was annoyed with my little beeps, and then I realized I have to unmute it so I can hear people. It is recorded. I saw the recorded button come through, so let me, yep, it is recording. And I do have sharing screen privileges, Mary, so that's good. And it looks like we've got a wide group of people that are attending, which is wonderful. I do see pathologists on here. I see people who are specifically nephrology trainees. I see pathology trainees and a lot of people also that are just kidney focused. People will continue to join. I do want to make one quick announcement. We've already had one instance of Outlook kicking people off of the distribution list because Dr. Foster was kicked off for last attendance time, which I think was in February, and did not get the invite. So seeing as how it's Dr. JD Foster, who is always here, somehow Outlook decided not to invite him. So if you know of other people who have commented that they were no longer getting invites, I don't know why Outlook occasionally does this. It just kicks some people off the list. People I had known I'd put on the list are no longer on it. So anyway, point being, if people say, oh, I used to be invited to those and I lost my invites, just have them email me again. I'm aware that this happens. And I don't know how to prevent it, but the invite goes out to about 60 people now. But obviously we know that people will come and attend, and then also they are recorded. And then Dr. Foster has been uploading them to the mysterious website that I do not know, but it has our recorded round sessions, the ones that we have remembered to record. So that's great. So, and then doctors, I see Dr. McLeland, my my esteemed colleague in the IVRPS, Dr. Hokamp and Dr. Nabity. Are you, Jessica and Mary, are you guys done with rounds yet? Or should I wait for a moment for you guys to be able to join? You might be going from one room to the next. Okay, well, in the interim, as we're waiting for them to be available, it sounds like they're kind of doing two different sessions. The case we have today actually isn't finalized yet. So we are waiting on the electron microscopy. I am confident of what the electron microscopy will show. It probably will be available tonight. So if anybody is interested in seeing the final report, just send me an email and I will send it out to everybody or to those that are interested. But it's an interesting case in the fact that the patient's already fairly well responding to the initiated treatment. And so we wanted to kind of discuss these kind of early responders as well. So, and I'll have to say, I'm not entirely sure which of the clinicians is it you, Dr. AT? Is that how you say your name? Okay, perfect. So if you just want to give a quick, if you have something to present, you're more than welcome to present something on PowerPoint. If you want to just talk a little bit about the case, that's fine as well.
Yeah, I didn't present, I don't have anything to present formally, but I can give a rundown of this case. So this is it was very interesting to me. So this is a 1.5-year-old male neutered Yorkie that presented to us in mid-March after being seen by the referring veterinarian for anorexia and 2 days of vomiting of a few days duration. And then the referring vet did basic blood work and noted what he called an AKI. We have no previous blood work on this patient, but he was presumably healthy. His creatinine was 2.3 with a BUN of 110 and an albumin of 2 at that point in time. And he was diagnosed with, quote, pancreatitis and an AKI and sent here. He had an ultrasound here with quite a bit of peritoneal effusion. And at this point in time, his albumin had dropped to 1.6. And then it was noted on ultrasound that he had changes consistent with possible pancreatitis, in that he had a hyperechoic mesentery and an edematous pancreas, but notably he had moderate effusion throughout the abdomen. And most notably at that point in time, at presentation, he had a creat of 2.15, and then albumin of 1.6 persistently. And then he had a UA with a quiet sediment, and a UPC was performed with, that was 48, which we thought was quite notable. And he became much more effusive in the next 24 hours to the point where he needed thoracocentesis. And then an albumin transfusion as his albumin dropped, depending on the machine, 1.4, 1.5, and he was, really effusive. And so we got an albumin transfusion, got a renal biopsy here. And while biopsy results were pending, the only therapy that was administered besides general supportive care, so we got, general supportive care in hospital, and to go home for his anorexia. But then the only therapy specifically for his PLN was a mg per kg of telmisartan and clopidogrel. And the other thing that was kind of notable with him was, although it was considered that he had quote acute pancreatitis, his PLI, the day of his ultrasound exam, was normal. He had no, previous history up until this point. So he had 2 rechecks since, so he was presented on 3/14, and he's been seen 2 more times through our hospital. And his UPC at initial presentation was 48, and then about a week later was 6.7, again on telmisartan alone. And then I saw him a couple of weeks ago, and his UPC was 0.3. And his albumin was 1.6 at presentation, which was, dropping in that periacute time period. Went up to 2.4 a few weeks later, and is then 2.6 at last recheck. And his creatinine was 2.1-ish at presentation, and then dropped to 0.7 a few weeks ago. And then at last recheck was 0.58. And so I thought this was really interesting in this 1.5-year-old dog, who the only diagnosis that was given him was quite presumptive as having quote acute pancreatitis based on clinical signs and an edematous pancreas. And he on his, I don't want to say too much about the renal path, so maybe I'll wait in case we were going to look at it. But anyways, he really only received, he didn't receive any other therapies, again, other than basic supportive care. So that's kind of his synopsis.
Great. Awesome. Yes. So we have seen some of these, and I think I'll show you the histology next, and we'll look at the immunofluorescence as well. Just as I'm getting those loaded, for those of you guys who are kind of, dabble in this, I guess I should say, Yorkies themselves are, and a lot of the nephrology clinicians will know this, they are a breed that is prone to have some degree of proteinuria. It's not surprising that Yorkies have an overrepresentation of kidney disease, and oftentimes not just generalized CKD, but like a proteinuric kidney disease. This is a very young Yorkie, and so a lot of the animals that we see on biopsy from Yorkies are much older. And so young Yorkies, my mind would be settled on possible maldevelopment, renal dysplasia, same kind of term for that. They usually are not UPCs of 40s, so that would be kind of inconsistent with the clinical presentation, but it's a young Yorkie. And then that degree of proteinuria, there are a few different things that can cause it. And immune complex disease is certainly one of them. Just a really awful podocytopathy that maybe then will progress to a segmental sclerosis pattern is also possible. We usually think we probably miss that early podocyte hit. And then when we get the biopsy, you know, at the time the dog is like 5 years old, now we're seeing the scarring associated with the previous podocytopathy. We might have just missed that time period. And then amyloid will do this. It'll have a really bad UPC. I've seen really high UPCs with that. So there's lots of diseases, and they're kind of in wide varieties of patterns, and also different treatments. So you would treat an amyloid case different than you would treat an ICGN case. Let's quickly go to the histology, and I have to open it. Oh, we already have it open. Good job, Rachel. So, and I will say, we got a very good core. It was a long core. Something was weird in the lab that day, that they were only able to section a portion of the cortex, and so they couldn't get the full length of the core, but it was still diagnostic, even based on the fact that I knew we had 2 Yorkies that they both were biopsied, I think the same day at Texas A&M. There were 2 different Yorkies that were biopsied. And so I quickly looked at the H&E so I could get a quick prelim to everybody if it was a very easy diagnosis. And so here is our core. We get a little bit deeper of a section later, just because I wanted to see if we could get a better sample. But it is cortex. It is a very well angled core to just basically hit the cortex and not go into the medulla. And then we can see there's probably 4 or maybe 5 glomeruli in this sample. We often like to have around 10 glomeruli, but you don't necessarily need it if the diagnosis, you know, jumps out at you in a few glomeruli, but 10 is usually what we prefer. So on H&E, I would say that there's a thickened capillary wall, and I can see this clearly even on H&E. I don't even need the special stains to guess about that. And then the degree of cellularity, it's a little bit increased, but it's mostly increased kind of in that mesangial region, that core of the glomerulus. And it's consistently thickened capillary walls. And then the hypercellularity, again, the nuclei are jumping out mostly in the mesangium and not necessarily in the capillary lumens. And then, so when I train my residents, the comment that I like to make is that when you're assessing thickness of a glomerular basement membrane, it's best to be looking at not the H&E stain. You want to look at a PAS stain, a trichrome stain, and even a Jones, because it's much better. It distinguishes the glomerular basement membrane from, say, let's say, podocyte cytoplasm or the cytoplasm of the endothelial cell. But even on the H&E, I can tell this is a thick glomerular basement membrane. So the PAS is next. So we're going to do that same glomerulus, that same capillary loop. It's a little fuzzy. I think I asked them to oh no, it's clearing up now. Okay, so when you're looking at capillary loops and trying to say, is the basement membrane too thick? You can use the comparison of the glomerular basement membrane to the basement membrane of a healthy tubule. So you have your internal positive control of how thick a basement membrane is allowed to be, but you have to be using a healthy tubule. We can't be using an injured tubule or an atrophic tubule. It has to look healthy. So here's a very good healthy tubule. Here's a healthy tubule. And here's how thick my basement membrane is allowed to be. And you can see that it's quite much more thicker in many of the capillaries. And so the consistency, the frequency with tubular basement membrane thickening is important as well. So see how thick these basement membranes are out at the surface. The other thing that happens with this type of disease is that the glomeruli kind of almost get rigid. So the capillaries just look wide open. They almost even look like a very I don't know, well-fixed type of glomerulus where nothing's like shrunken or autolyzed. And the reason they're going to look like this is obviously because of the disease. They just look very stiff glomeruli. And then let's see what the other ones look like. I can't see up here. I don't know if that's a little bit I don't think that's a little bit of sclerosis. I think that's just overstaining. We trust that their dog is proteinuric. There is some pink material within the tubules. That being said, I don't necessarily, it's not required for me to diagnose proteinuria or to say that it's consistent with proteinuria. There's plenty of dogs. This dog has a UPC of 40. And we're not actually seeing that many protein casts in the tubules. But I wouldn't, it could be something that if you don't look at a lot of kidneys and all of a sudden you start to see protein casts, then maybe you want to go back and look at the glomeruli. The next stain I think is the Jones. Oh, no, it's the trichrome. Okay, so this one we had to repeat the trichrome just because of the first stain was kind of faint. So this one actually has a lot more glomeruli because it's deeper in the core. So we have now 4, 5, 6, 7 glomeruli in this a little bit longer, deeper section of the core. And just for like a comparison, in human medicine, when we read human kidney biopsies, we get multiple step sections through the core. So we don't spend that much money in veterinary medicine. So it's not like I routinely get step sections. I can ask for step sections if I want, but in human medicine, they all come to me once in the morning. We get it, you get the 4 stains and you have 3 repeating slides of the 4 stains. So in total, you have a total of 12 slides per case to look at. And usually you get 2 sections on each slide. So that would be 24 sections of a kidney biopsy. And you're using all 24 sections to try to see, is there scarring? Is there a crescent? Is there necrosis? Because those tiny little infrequent lesions can have a big impact. We don't do the same thing in veterinary medicine. Okay, so this is a little confusing if you don't look at a lot of kidneys, but I will tell you that the glomerular base membrane should be blue. It is made of collagen. So it is a composite, mostly type 4 collagen, but also has some other laminins and proteoglycans inside of there. So a normal glomerular base membrane should be blue. And you can see that these are just completely red. And so all of that red material, the only thing that will do that are deposits. So this was immediately diagnosed as immune complex GN, and can even go higher. I think that's as high as I can go. So here is a capillary loop, and here's a big red blob. Here's a big red blob. Here's a big red blob. And you can see this faint blue line. That's the glomerular basement membrane itself. But all of this red material is the immune complex deposition. And this is a little tiny fuzzy just because of the scan. But you can start to, if you're focusing on the blue versus the red blobs, it jumps out at you. Once you know what you're looking for, it really does jump out at you about what's wrong with this particular glomerulus. And it's repeated throughout all glomeruli. I get a little nervous sometimes when we talk about being able to diagnose immune complex glomerulonephritis on light microscopy. And the reason I get concerned is a lot of times this will tell the clinician what to do therapeutically. So they have immune complex disease. Their goal is to try to get rid of the immune complexes. So they usually go for immunosuppression. And so in this scenario, I get worried if I say, oh, you see red nodules, it must be immune deposits, that maybe a pathologist would only see like one capillary loop that possibly has red nodules on it and decide to make the decision about saying it's immune complex GN. So it really, if you're going to call it on light microscopy alone and not have immunofluorescence and not have electron microscopy, then it needs to be repeatable and it needs to be in many glomeruli. You need to be able to see these red nodules on trichrome on many glomeruli, and you also need a 3-micron section so that you are looking at a specifically thin section that has the availability of being able to visualize where the GBM is, where the cells are, and where the complexes are. And then the other thing that you can gather from this trichrome, well, actually, I'm going to ask the, let's see, let's put in I want the pathology people in the room. What else would I be looking for in a trichrome that I'm not actually seeing here, which is a good sign. So if anybody can put it in the chat or speak up, what other things would you look for in the trichrome for a kidney biopsy that would tell you stuff about prognosis? And actually anybody can say it, it's not just pathologists. Everybody is being shy.
Interstitial fibrosis.
Oh, we have a message. Awesome, Dr. McKee. Yes, fibrosis. Awesome. Thank you, Dr. Galbraith, too, as well. So it's a fortunate stain because sometimes it shows us immune complexes. And so you can make a diagnosis within 24 to 48 hours and we don't need to wait for the EM. But the other thing that I'm looking for any case, a case of segmental sclerosis, a case of amyloidosis, a case of podocytopathy or anything like that, I'm still going to score and evaluate the interstitial fibrosis. And you can see the blue is the tubular basement membrane. Remember, it's a basement membrane, so it's also made of collagen, so it will stain blue. And you're expecting to see the tiny blue lines of the basement membrane, but I do not see interstitial fibrosis that is of concern in this kidney. There's a tiny bit of expansion here, but that's probably from a little bit of edema within the interstitium. But in general, this looks like a very unscarred, not necessarily happy kidney, but an unscarred kidney, which is good. I think the next slide should be the Jones, maybe. I think we had to scan a few extra slides for this because of the, oops, is it loading? Okay, here it is. Yeah. This is just a folded one, I think. Wait, hold on. Oh, go back. That's why. I did that. Did that. Sorry, that was a different case, the 24 case. Oh, it keeps doing this. Let me go back to here. Okay, here's the Jones. Okay, here it is. Okay, so now the Jones is a silver stain, and the silver binds to basement membrane material, and it also binds to the material that's in nuclei. So usually what you're going to see is stained black is going to be basement membrane material, and then you'll pop the nuclei of the tubules per se and the glomeruli, those will pop out as black as well. And then our counterstain is like an eosin counterstain, so it's a slightly pink. And so what we use the basement membrane stain is to see if there's evidence yet of remodeling of the glomerular basement membrane. So sometimes people say that this is almost like a poor man's electron microscopy because it's cheaper. That's why it's poor man's. But you don't get the detail that you would get with electron microscopy. There's going to be cases that will have basement membrane remodeling that you can't pick up on the trichrome. But in a chronic ICGN, you can see the type of remodeling that would be saying, okay, these deposits have been here for a while. Dr. Hokamp, please quit messaging on other things because you're distracting me. So here we have our capillary loop. And it should be smooth in a normal, healthy dog. And so this dog is not healthy, by the way, but the fact that it is smooth means that whatever's going on in the glomerular basement membrane or in the glomerulus itself hasn't yet incited a lot of basement membrane remodeling. For the pathologists that have done some of this work or have been learning the revisions of how we characterize glomerular disease, these spikes and sometimes the pinpoint holes would be what we expect with a remodeled glomerular basement membrane from this type. So we would expect to see tiny little spike-like projections towards the urinary space if this had been so chronic that we had had time to remodel the glomerular basement membrane. But in my opinion, I don't have the EM yet. I should have it later today. But in my opinion, this is fairly recent. That also is consistent with the history of a kind of an abrupt onset of clinical signs. So these deposits came, they landed here, they took up residence here. And if they stay there, the glomerular basement membrane will become remodeled. But if they get dislodged and go away and new deposits don't form, then maybe we can have some residual, we can have a loss or recovery. Recovery is the word I want to say. Recovery without actually having significant damage to our glomerular basement membrane. So the silver, again, and that's the other thing is that you can use when you're saying, is the basement membrane itself so thick? the basement membrane should be thinner than our tubular basement membrane. So the basement membrane itself isn't thick. What we were looking at before with the PAS and the H&E, the reason it looked thick was because of all those deposits. So it's not the basement membrane itself that's thick, it's the fact that there were deposits sitting on top of here, and that made everything look thicker than your tubular basement membrane. Okay. Sorry, I got a little bit distracted and off there. So let's see. So that's the histology. Does anybody have any questions about histology?
Well, not a question, but a couple. One, the Jones is a finicky staining procedure, and the first thing you have to really ask yourself is whether you've got a good stain, and you can blame the lab if you don't, but you have to have, even the best of them don't get it just right every time, and so that you have to interpret what you're seeing. It's a much harder one to look at, but the first thing is there really much silver embedded in the material that should have it. The second thing is that one of the reason for the profound proteinuria is the disruption of podocyte function. It's this case illustrates how important the podocytes are, which are lifted. Ultimately, she'll have EM that will show it and whatnot, but all these immune deposits are really not damaging the GBM. They're interfering with podocyte function, and the GBM itself is there and not changed a whole lot, but the podocyte contribution to maintaining the perm selectivity of the basement membrane. This is a wonderful example, if you will, of how much the podocytes matter. Okay, so.
Yep, I agree. And so I would say we don't often get cases that are this abrupt onset and this severe. This is most of the time we'll have a history of, oh, it's been going on for a while, and then we finally decided to biopsy. So the quick rush to biopsy actually helps us get a very early representation of this type of disease. Any questions from anybody else about the pathology? I'm sorry, the histopathology. We'll move on to immunofluorescence.
No, and I just want to clarify. Yeah, he was biopsied within 48 hours of presentation, so it was very quick that he was biopsied.
Okay, I need to quit this 1 second, and then I need to get.
While she's doing that, I'll offer that if I'm a dog and I have proteinuria, the best thing you can find for me is early membranous. It's the most treatable, reversible, fixable problem you can have.
I agree with that. Let's see. I need the IF. Okay. Hold on 1 second. I'm just getting the images. Yeah, let me do this the other way. Sorry, I'm going to switch the way I want to do this. Okay, so I'm just going to go from the reports because those are the pretty images as opposed to. I know I have to share my screen. I'm just getting to the right place. So I would, I think even before we had the trichrome, when we just had the H&E and the PAS, I sent a quick email saying like, I am pretty darn sure this is going to be membranous. And this is going to, or at least it's going to be immune complex disease. And so I was able to give you guys a quick, response. And I think you had said you'd already started the telmisartan at that point. And so even before the information about, hey, this dog could benefit from immunosuppression, the telmisartan already started to do some of the work as well. So this is the just some photos of the immunofluorescence. I don't know how many glomeruli were in the IF sample. I think there are quite a few. But IF is the most difficult. 17, okay. The most difficult to assess, I guess I should say, to be trained to assess, because there are inexperience, there can be an overcall of positivity where it is not a granular pattern. And this is specifically veterinary medicine because it's different in human medicine. But what you want to see for a diagnosis of immune complex disease are actually discrete, tiny little DIT dots. Here's one and here's one. Each one of those is an immune complex. The granularity is important. If you start to see blebs like this, that could be other stuff. It can be plasma that's entrapped in that area. So sometimes hyaline will get pushed, or plasma, it becomes hyaline on the histology, but sometimes plasma will be pushed into different areas it shouldn't be. And sometimes you'll have an area where it's just a whole bunch of very splotchy, very strong, like 3+, 4+, but splotchy like material, which doesn't have a granular DIT dot pattern. And in that scenario, you can't call it positive. You can say it's labeling, but it's usually, it's almost always non-specific labeling. Cases of amyloid will have non-specific labeling because amyloid fibrils are very, this mesh work, and we assume they're quite sticky. And so the FITC labeled antibody we use for immunofluorescence will accidentally bind there. So it really is about pattern and seeing granularity, and then seeing it on a certain number of stains. So IgG tells us that there is heavy chain labeling, which is good and important. The C3 is very good at granularity. If you can see all of these tiny little granules, those are all deposits, because the IgG, the heavy chain with our whole immune complex, has bound to the glomerular basement membrane. And in that location, it's activating the complement system. And that's why we see staining with C3. So the C3, the IgG, and then the last one, which is being shown, these are tubules here. C3 will just bind tubules just because. And then the lambda. So our heavy chain is IgG. Our light chain for the immunoglobulin is the lambda light chain. Dogs don't really make kappa, so we don't even do that stain anymore. But every single one of these DIT dots is an immune complex. If I had a glomerulus and it just had this splotchy, very strong bit, just that part, and everything else was black, I would not call it positive. It really has to be a granular pattern to be called positive. That's very different than human medicine. Human medicine has a very different way of scoring this because they can have linear staining. We don't see that in veterinary medicine. I guess thankfully, but it means it's less number of diseases for me to try to diagnose. Okay, so the lambda light chain, the IgG are the heavy and light chain together. They are the immunoglobulin. They have bound some type of antigen. We're not entirely sure what the antigen is. They are now stuck to the glomerular basement membrane, and they have activated the complement system in that location. The podocytes are upset because they're sitting right next to those immunoglobulins, the antigens, and the activated complement system. They usually retract their podocyte foot processes, and the patient becomes overtly, severely proteinuric. So I will say, Doctor, so the dog had already been discharged. We had recommended immunosuppression, and it looks like the patient started recovering even with just telmisartan and without kind of a more directed type of immunosuppression, which we would normally go for like a mycophenolate. It takes a little bit for the mycophenolate to work. So it's good that the patient has responded to other things as well. We've had a few cases like this, and I'm kind of upset, not upset, but I'll put you in touch with Dr. Adedali. So he's had a few cases that were membranous as well that responded on their own. So spontaneous resolution of membranous is something that can happen. It happens in humans, and we have seen it in dogs, where basically whatever the impetus to form the immune complexes went away, and the dog gets rid of those deposits that are sitting on the glomerular basement membrane spontaneously, and the dog recovers without immunosuppressive therapy. And in humans, they usually would not immunosuppress these patients for them to get-go. They would see if they're going to be a spontaneous recovery person. So that
And
would
the
be their
category of
first.
people that do that is about a third.
Yeah. So they would just say, okay, are these people going to respond on their own? If that's fine, we're not going to mess with giving them drugs. I do know the case that, and I don't see any, is anybody here from AMC? I'll reach out to Dr. To Nav, because I think the patient that I'm remembering, which happened last year, did spontaneously recover, but I think it recurred, and then I think the dog did much worse. So I can try to find that one in my database as well. But the concept of, even though he recovered now, it doesn't mean that it's going to be completely a normal dog from here on out. And the EM will be helpful later in the afternoon or tomorrow when I get it, because I'll be able to assess for GBM, remodeling the glomerular base membrane. But recovery now is good, but the dog could have a recrudescence of angiogenemia and immune complex deposition. So then if that happens, then, making that decision to go ahead and add in mycophenolate at that time would be useful. And I don't know, for the clinicians that are on here, I see Dr. Lobato, I see Dr. Jepson, Gilad's here. What would you guys do with this dog that's already kind of doing well on its own?
For me, probably nothing. So if UPC is decreasing and normalizing, I would not probably immunosuppress at that point. Seems like the disease is responding. We see, we see these cats, not dogs, with severe protein-losing nephropathy, and those cats oftentimes are the young cats, more males than females, and they have tremendous proteinuria and high UPC, and we oftentimes immunosuppress these animals, and oftentimes, or not oftentimes, but in many cases, they have complete remission of the disease, and we wonder whether this is us or just spontaneously resolved. But I think for me, if I have normalization of UPC, I would not go ahead and immunosuppress at that point.
Let me point out that in people, for sure, there's a category of membranous pattern of injury that is a specific kind of autoimmune disease where the antibodies are against an intrinsic epitope in the underneath the foot processes of the podocytes, and I'm not sure, and that's a substantial but not the entire set of membranous nephropathy. I'm not sure we see that kind. I think we see in dogs, speak less, I'm not sure I can speak that this is true of cats, but at least in dogs, I think what we actually see are immune complexes where the antigen, although we don't know what it is, isn't really an intrinsic part of the filtration barrier. And so comparing what happens with spontaneous resolution or treatment with just antiproteinuric therapy without immunosuppression and those kind of guidelines from human medicine about the treatment and monitoring and intervening only if kind of rules about people with membranous probably don't apply to dogs as quite as predictably as you might hope. It's wonderful when they get better, no matter why, and I'm pretty sure that some might get better on their own, but I'd probably treat all of them and then not worry so much about which component is the ACE and ARB inhibition or the immune suppression inhibition. And I just get them better and then back off and watch like a hawk for any sign of recrudescence.
Quick question. Have we had a follow-up biopsy from a case like this that has spontaneously regressed to verify that the immune complexes have resolved? Because we have had follow-up biopsies from ICGN cases, and even despite a normalization of UPC, from what I remember, there still are oftentimes immune complexes present, and that should take probably a decent amount of time to clear, I would think. And so I'm just curious if we've had any repeat biopsies to show whether the complexes are still remaining, but for some reason the proteinuria is better, or if they have truly dissolved.
We've had cases where we've had a few cases where the EM just shows the holes, the classic almost stage 4 of human membranous, where it's just, you see the remodeled GBM and you've seen that there used to be deposits there and they aren't there anymore. We've had cases where we can see the dissolution happening at the time and there's still deposits. And then we've had one where it's just holes. Those are very rare. So we do know that eventually the deposits can be physically removed. But we do not have, like you were stating, and I was looking for the case that I was mentioning with Nav about almost like spontaneous remission. And I know it was last year, we were discussing it in early April. So I assumed it was being, biopsied probably in February or March, and I'm not finding it immediately. I do remember, I think the dog came back and it was worse. So I will reach out to him actually, or I could just text him and see if he's available right now. But I think that this shows the dog can make immune complexes. For the current case we're talking about with her Max, the dog is capable of making immune complexes and needs to be monitored. And if there are further episodes, and I would even worry about any kind of a episode, not necessarily something where all of a sudden the animal's having a fusion, but like rechecking the UPC, making sure that things are stable. And if the dog has a GI episode or something like that, like this, the way this one started, making sure you're going back to look at the urine at the same time. And if it does see an elevation on UPC, then you're going to have this in your back pocket to know, okay, I can immediately start immunosuppression. And I don't know, you might have started immunosuppression based on our reports, because I know you went immediately to telmisartan, but I'm not sure if you immunosuppressed based on just the histology.
We hadn't, because by the time we got the report, he had already had a UPC that showed a massive reduction. So by the time we got the report, which was quite quick, but even in that time, we had rechecked him less than a week later, or exactly 1 week later, and his UPC went to 6.7. And at that point in time, his creat had gone from 2.1 to 0.7, and the albumin went from 1.5, 1.6 to 2.4 in 1 week's time. And so he was doing so much better. And we knew we had other things pending. We held off immunosuppression at that visit and then saw him again. And then things continued to improve with, again, telmisartan alone at that point in time, which maybe wasn't the right call. I mean, I think this is one of the reasons why I think it's so interesting, because he really did not have disease specific therapy.
Yeah, and I just found the case. I went back to my text conversation with him, with with Nav. And the case that was a spontaneous responder was this one that was a lab. And I know you can't see it, but I'm looking at it right now. But anyway, it was originally diagnosed as an AKI, unknown etiology, and then they did UPC was not nearly as high as yours. It looked like the UPC was around 2, but they went ahead and decided to do a biopsy. And I saw just get the report up for myself really quick. Very early immune complex disease, and it was a membranous pattern. And I would say it looks very similar to histologically to what you had. And the dog was quite young, although it was a Labrador, it wasn't a Yorkie, it was only 2 years old, 2.5 years old. Then they did, so the dog was biopsied, I think, in early January, and I think they went and got the biopsies, and then they also did maybe 5 days later, got the blood work from the day of, hold on, Liz. The dog was biopsied, and at the same time they did the biopsy, they went ahead and grabbed UPC and blood work. because they had already, got everything scheduled, got everything ready. They sent the biopsies to us, and by the time we even got the sample, the UPC had decreased, and it went from 11 or 12 beforehand, and the day of the biopsy, the UPC was 2. And then the azotemia had also started to resolve spontaneously. So we basically got the samples, and they were like, hey, you can probably cancel them. And we're like, no, we want to see what it is. And it was really bad immune complex disease. So I will make sure that I know what happened with that dog, because I can send him now that I know which one it is. But I do think that sometimes maybe they get these early hits. And, what if this dog had never had a urinalysis run because the whole clinical signs were vomiting, lethargy, and they thought it was a GI thing. So what if they had never done a urinalysis on this dog? They would have never known that the UPC at that time was 11. So I guess maybe this is just kind of like the entity that we see, or maybe, sorry, how do I want to say this? Maybe there's just a group of young dogs that can have this hit and they get missed. They never get biopsied. And then let's say 5 years down the road, now they've got scarring, and now they're going to be a CKD dog. And then that's when I see their biopsy samples. And so I'm like, well, it just looks like a lot of scar tissue. So it's an interesting scenario, and we should probably look that. I know George has identified a lot of dachshunds. I think dachshunds that are young that have a membranous pattern as well. Yes. Also, we do know that there's a lot of glomerulonephritis, pancreatitis overlaps. Thank you for putting that in the chat. It was one thing I wanted to say. That's always kind of in the knowledge base of what happens with glomerular disease. They often have concurrent or overlapping pancreatitis syndromes. And nobody's actually done an analysis of that about how that would work. Okay. Any other questions? George, you found the dachshunds, right? That were like pretty young and they all had membranous. Unless George might have left. It seems like we've gone down further a number of people. He might have been removed from well, not removed, that sounds bad, but maybe he lost his connection. So he's probably out on the golf course calling in from the Zoom. If anybody sees him rejoin, remind me to ask him about the dachshunds. There is a quick, if there's no other questions about that case, I think we've kind of at least given you a pat on the back for curing it with telmisartan, and also the concept that if the dog does have another event, that maybe you can reach out earlier and do and feel confident that you need to immunosuppress because you already know the dog has a propensity to make immune complexes, and see if then that maybe prevents continual relapse, because some of these dogs can relapse. Any other questions about that particular case? Would you rebiopsy? Okay, I will say, and I always do this blurb anyway, because we need to learn more about these cases. We will examine biopsies at no charge for patients that have been biopsied before. So repeat biopsies are evaluated at no charge. I keep saying this like I'm at Texas A&M and can make this decision. I'm pretty sure that's how Dr. Hokamp and Dr. Nabity are okay. Yes. Usually we'll only do we'll only do histology. We don't need to do the electron microscopy and everything. But if you, do another SDS page, check with that to see if it has the same high bands that we're concerned about. So I think that you could do that without having cost be a factor, if that's part of your decision. Like, I don't want to have to charge the owners more just because I want to learn about the disease process. So that's one thing, but obviously it's a Yorkie, it's a small dog. If it's not going to do well with biopsy, if you already have other concerns, then I would say, no, I don't need to biopsy. You can just administer care based on the fact that you know this is a dog that can form immune complexes. Does that help with anything? Dr. Hokamp says it is okay that you can rebiopsy and we will not charge you.
Yeah, and your comment about the SDS page, following that, like in this case, we have that banding pattern where there's multiple bands above 200 kilodaltons. And I know JD has been sending in cases periodically that have been biopsied with a follow-up SDS page as they're, monitoring treatment, trying to see if there's indications on the gel that say, okay, we need to start, restart treatment if protein's starting to go up. We're still following this a little bit, but absolutely happy to redo SDS page also at no charge for these.
And given the variability of UPCs with day-to-day variation, do you think it would be worthwhile to do those in concert, Jess?
You mean like the pooled sample? Is that what you mean?
Yeah.
No, well, either pooled or I mean, if you had like a spot, so these are actually not pooled. These were spot checks upon coming to the hospital. But let's, I mean, right, going from 48 to 0.3, that's pretty damn convincing.
Right.
But if it was less overt, right, or or convincing that there's an improvement, but let's say still not normal or not as close to normal, would it be worth doing SDS page, if they're stable-ish, let's say, with a UPC of 0.5 even, would it be worth repeating that and looking at banding patterns to see if some of that protein is inappropriate given the molecular size?
Yeah, I mean, we certainly could. And I think that's another area that we're still learning a little bit about. So for example, Jessica Quimby has some cats that she is periodically sending me SDS page to follow. And she's got one where the UPC has markedly decreased. And so what I do is I run it as a USG loaded gel, and then I run it as a max loaded gel, and I compare it to my previous one. And when I look at the USG loaded lane, it looks almost normal, maybe mild glomerular damage, but then the max loaded lane looks very similar to the original banding pattern that we saw, where there are those high molecular weight proteins still there. They're just in like infinitesimally small amounts. And so, which I would not see that on a normal max loaded sample. So I know that there's still something there. It's just dramatically improved. So yeah, I am absolutely happy to do that on these, the low UPC ones. And again, even if it's just for funsies, bring it on up. You know where I live, up here.
Okay. And I just reach out to Nav to see about his case, the one that got better spontaneously as well. I will make sure I have that information included in the final part of your report, because I hope he'll get back to me today. That just kind of says what has happened in other cases that we have followed. And like I said, there is a set of dachshunds. I think it's dachshunds. I'm pretty sure it's dachshunds that that have been fairly young, that we have diagnosed early membranous or a pretty prominent membranous. And Dr. Lee's kind of picked up on that thing too. So, maybe, like I said, maybe it is a signalment thing of like when they have a young onset of immune complex disease, they can spontaneous resolve. And then if we missed the biopsy at that time, we would never have known that was the issue. There was go ahead. Sorry.
Yeah, you're right. It's dachshunds with membranous, and it was only several, so I don't know, that we have enough evidence right now to say it's definitely breed related, but it's 3, I guess, or 4. So yeah.
Well, we could look at our membranous. I mean, you have a lot of the membranous cases already for outcome studies to see how many of them fall into the very young cohort, like the less than 2 years, and I don't know, to see if they do better. But
yeah, that's a good thought.
There was a possibility of us discussing an autopsy case from Texas A&M. I don't know necessarily whether or not we have time, since it's only 5 minutes left. But if I don't know if the pathologists for the case want to stay on, I can at least discuss it with them if they have any questions. Yeah,
they were on. I'm looking. Yeah,
is here. Yeah.
Okay. Do you want me to? So for others if anybody's interested in. I'm more than happy to kind of go over through the case. We only communicated via email, but for those of you guys who are don't necessarily need to look at more pathology, we will reconvene next month, and we will send out a case request. This one was actually quite easy to do because the clinician approached us about presenting it in rounds. So we will try to keep you guys alerted that there will be rounds in May. It'll be the 3rd week of May. If, like I said before, as my public service announcement, some people have already been kicked off the Outlook invite list. I do not know how it happens. I promise it's little magic elves. This isn't me doing it myself. So if you guys know of people who want to be added to the list, all they have to do is email me and I just add them to the Outlook invite list. Okay. Okay, so, oh wait, Nav said, oh, is the clinician still here? Yeah, the dog did this one for the case, the similar case from your Yorkie. This one was a lab, but it was quite young. The dog did relapse and ended up dying. So
Great, yes, that's really encouraging. Thank you.
I think
You just gave us so much hope.
Sorry, no, it said, and then we did get samples from it. They did send us autopsy samples and it actually was a lot worse the second time. So the dog did relapse within that same year. And so I think that they didn't catch it. And I think that the cause of death was probably a thrombotic event. So I would just monitor very closely. And I don't think Nav did anything to do immunosuppression. But I can put you in touch with him as well, just to kind of compare and contrast. But I think it does tell you the dog can make immune deposits, and then just monitoring is going to be a big step for your case. I apologize. Now I give you bad news. I'm sorry.
Maybe this one will live forever.
It's a Yorkie. Of course it will. Mary, you said this thing was via email. Didn't you give me the case?
Yeah.
Let's see.
Should I stop recording or should I continue?
It doesn't matter to me. I mean, I don't, it's the clinician, whoever,
Going on.
what email, what should I look for in the email? Like, is there a name or something that I can find the link?
Yeah. Let's see. Let me find it and then I can so if you look up
If you search your glutaraldehyde for EM or
I got it.
Hollis, you
was
found
it.
it.
I knew it'd be something that would be like. So that's the link. Then you had that one. Okay, so this is a 4-year-old intact female, intermittent dry cough, hyporexia. She was a breeder. She had her last litter in November 2022, excuse me. She had never had blood work, then had a urinalysis because she had vaginal discharge that showed a little bit of protein. And then she went from Wisconsin to Texas. She's a cattle dog. And then she comes back in with, they thought maybe pyelo or Lyme disease or a lepto. And she has now a severe azotemia and a UPC of 22 and is hypoalbuminemic and hypercholesterolemic. And then she was discharged, but then I think she died. Oh no, I guess maybe she was euthanized because of quality of life, maybe. And I'm trying to get to the link, so I don't know where the link actually is in the thing.
it was in one of the later emails, so it would have been an email from April.
I got it. Sorry. Okay, and then I'll show you my screen. So H&E. For pathologists that are still on the call, these are the best types of samples. You want to have all the way from the capsular cortex, and then if possible, get papillary urothelium on that area. So I like for this particular sample, although it's a really good wedge, I don't know what's going on with the doula, so it's not as helpful. I prefer when we have the papilla included in it, so I can evaluate for papillary necrosis. This is the H&E. This is an autopsy sample. The point of the H&E for this particular case is being able to identify all of this horrible mineralization of tubular basement membranes, sometimes within tubular lumens. Sometimes there's even mineralization of the glomerular tufts themselves and a Bowman's capsule basement membrane. So that basophilic material is severe for mineralization. And we'll look at the glomeruli with the other stains because it's a little bit more easier to interpret. I assumed if you guys did a von Kuss on this, this would just be all brown. The other thing I'll use the H&E for is to qualify my type of inflammation. So it's a little bit of a mixed pattern, lymphocytes, plasma cells, there's some neutrophils, probably a few macrophages, but it's not an overwhelmingly inflamed kidney. It's more of a mineralized kidney. Here's what you can see, the mineralization of Bowman's capsule out here on this corner. So I've seen times where really severe mineralization will have entirely mineralized glomerular tufts as well. It doesn't necessarily tell me pathogenesis, but it does tell me that it is a horrible prognosis. I have never seen this severe of a mineralization in a dog that survived post-biopsy longer than a month. Like usually we'll have done the biopsy, I'll have told them it's mineralization, and then within that month, I'll get follow-up that the dog eventually died or was euthanized for clinical signs. Oh, hold on, I did this wrong. So the PAS, it's not showing right now. Oh, here it is. Okay, okay, so the good part for the PAS is going to tell me cellularity, and then it's also going to tell me where the cells are located. So you're allowed to have 2 to 3 mesangial cells per segment. And this particular one has 10, this particular one has 8 or 9. So we have increased number of nuclei within mesangial zones, and then you're allowed to have 1 to 2 nuclei within capillary lumens. And you really want to look at capillary lumens that are kind of at the periphery, and you include your endothelial cell nucleus in that count. So here's an endothelial cell nucleus. This is a leukocyte nucleus that's circulating through. So we have 1 to 2 in there. Let's see. Let's get a really good here. This one's quite thick, and it's one of those things where it's almost similar to like when you get instructions to do a mitotic count. We're like, go to the most mitotically active area and do your count there. Well, then that kind of makes you feel like you have to count everything so you can figure out which is the most mitotically active area. For me, it's a little bit easier with glomeruli because I can say which is the worst glomerulus and let me start there. And so I just said you're allowed to have 1 to 2 nuclei in a capillary lumen. And here we have 1, 2, 3, 4, 5. Here we have 1, 2, 3, 4, 5. So we have too many nuclei within capillary lumens. And then we go back to that count of mesangial cells. Again, way too many mesangial cells as well. Podocytes, sorry, are upset. They have very prominent nuclei that are oriented towards the urinary space. Some of them have protein reabsorption droplets, like this guy right there. This guy is a podocyte here, and he has resorption droplets as well. And then the other reason we know podocytes are upset is we have adhesions, which means there's a synechia between this segment of the glomerulus and Bowman's capsule. Here's a little bit of hyalinosis. That's what I talked about when plasma gets pushed into places it shouldn't be. So we probably have lost our endothelial cell in that area, and plasma has kind of been squished in there. So we have a very hypercellular glomerulus. We have evidence of podocyte injury. We have hypercellularity at both the endocapillary and the mesangial components. And then these little protein droplets will also happen in the parietal epithelial cells. The trichrome, I honestly not necessarily sure if I saw, I think I did say I saw immune complexes. Let's look. Oh yeah, so this is going to be a little bit of a good comparison. Okay, so for the other case that we looked at earlier with the membranous pattern, honestly, are there people still here? Wow, okay. The case with the membranous pattern, and I said you really want to see those little nodules. Because I know what type of pathology this is, you're allowed to have a lot more blebbing with your immune complexes for this particular case. So that's just because of the pattern. It's a membranoproliferative pattern. And so oftentimes you'll get more of like a big, huge immune deposit because it basically gets lodged underneath endothelial cells. And so on EM, you'll see these huge deposits, not discrete DIT dots like we saw with the membranous from the earlier case. And that's, and in humans, when we see them and they're quite like this, we'll say that they're wire loops. And we will even say that they are hyaline deposits because they almost look like hyalinosis, but we know they're immune complexes. I know that means we're cheating a little bit because we just are going by what we see in other from experience, but I guess experience is worthwhile in some scenarios. So these little red things, I will guarantee you, if we ever did EM, would be there would be a whole bunch of deposits in this glomerulus. That's kind of out of focus. Let's see. There's also interstitial fibrosis, but it's not like if this dog had recovered and we would have had maybe this area would have been scarred, but a lot of the kidney would have probably remained unscarred. Oh, here's a good one. This is a good, okay, so all of these little things are immune deposits. I just speak from experience. Let's look at the silver. So I guess I should say that because I think there was the silver was convincing to the clinicians that there had been remodeling, but they weren't really entirely sure what to do with the trichrome. And so I think that was the area that I could help about, like, hey, no, those would be, I swear when you do EM, that would have had an immune deposit in there. The type of remodeling we're going to see for a membranoproliferative, like a very hypercellular glomerulus, is present in here where you have double contours. So here's one little black area that's part of the GBM. Here's another little area that's part of the GBM. And then this tiny little clear space is where the immune deposits are setting up shop. So you want to look for a black space, a light gray space, and a black line. So black line, light gray space, black line. And that's where you can be convinced that it's repeatable. It's not just one single area. You see it on a lot of glomeruli and you see it in multiple places. So black line, dark gray space, black line. And then if you know what you're looking for, then you go to new glomeruli and you do the same test. Like, am I seeing the black line, the gray space, and the black line? And based on this, I told them that it was 99.9% sure this was an immune complex GN. I don't think you guys, Mary and Jess, were going to do EM and immunofluorescence on this, were you?
We haven't yet.
Right.
I guess
Right. We had not, I don't think we had planned to yet without further discussion with Paula.
Yeah.
I mean, I think that even if you just wanted to do the IF and just do a lambda just for fun, you could, if you just wanted to have it in your back pocket to say that's definitely what it is.
Okay.
But I mean, I don't know if you necessarily, I would have no problems signing this out as immune complex GN and with that confidence, it's what it is.
Okay.
Did you guys get urine on it though?
No.
Oh, yeah, then maybe not. I mean, it just depends on what you want to do with your research money.
Okay. I'll talk.
Hi,
with-
Dr. C. It's Paula here.
Hi.
Thank you so much for reviewing the slides. That was very helpful.
You're welcome. And like I said, it is one of those things where because I get follow-up on so many of my cases, because I have the EM and the immunofluorescence, like there's just really nothing else that would do that besides immune complex disease. So I'm confident that's what it is. If they just wanted one more piece of evidence so that we could follow it or keep it in our research archive, then I could understand that. But there's nothing really else that does that. So
That sounds great. Yeah. And then for pathologies, for us, we don't have much funding for that. I'm not sure if the clinicians have. And if it's not that interesting for research, especially if we don't have urine, that's...
I would say like if Dr.
we're good.
Hokamp had urine, then I would say like that would make sense to use the money for it because we could keep it in one of the studies for her. But it is I'm not entirely sure. Did we figure out what the antigen from the infectious disease panel was? There something that
So it was had high levels for C6 for Lyme disease.
Okay.
So
Okay,
and
I did
Lepto
think
was
that.
negative. Yes.
Okay, perfect. So we know that makes sense. It's going to be one of those things where the C6 is telling us something, whether we really think it is the antigen for Lyme-associated nephropathy, nobody really knows, but it is a marker for developing immune complex disease. So,
And we
okay,
can always go back to our freezers, go back to the records, see if they did a urinalysis at all while the dog was in the
They
clinic.
did. They did.
Okay, so we might have some urine saved if they said save for chemistries. So we can go back and just check on that, and it won't have been stored ideally, but it will have been frozen. So yeah, we'll go back and look.
okay. Well, and just Mary, let me know if I need to do anything for that report, because I think all I did was communicate via email.
Yeah, I think that's up to Paula. If
Yeah,
that's
for
not-
me, that's great because I put an addendum. I
Okay,
mentioned that
that
I
sounds good.
consulted with you, and we're very grateful. Thank you so much.
Okay. Any other questions from people that are still listening to me ramble? Okay, so we will reconvene in May. I just got an email. I do need to, so is it Dr. Fishgold? Is it, how do I refer?
Sorry.
A T.
It's at T,
A T.
like a T in the road.
A T,
Texas A&M has like whatever you come in as, you're stuck with that for forever. So I was
Got
a
it.
student here with a different name over a decade ago, and forever my Zoom will look like that.
Got it. Okay. Okay. So I saw your email about adding you to the list, so we will definitely add you to the invite list for future rounds. Okay. Sounds good.
And I will be able to get on the scope in just a few minutes to do the case you did today and the one just before it, which are both A&M cases. At least
Oh
I
yeah,
hope
both of the Yorkies that were okay. I'm not sure if I'm supposed to be running Henley in for another repeat UA, or not UA, urine culture. So I'm going to text my clinicians to see if I need to take my dog in for that. If not, I will be working this afternoon. Otherwise, I will be working in the evening, but I will be getting those cases that you get done. And
Did you
Dr.
get-
McClelland is going to work on our cat. And anything else?
Did you get enough responses, Rachel, about your cat, your dog? Your
I
own
didn't
pet?
get any.
I think I had a lot of thoughts, but I didn't want to